Good afternoon. Welcome to the CSG Policy Webinar Series. My name is Deborah Miller. I'm the Director of Health Policy at the CSG headquarters in Lexington, Kentucky. Welcome everyone to the call today. Our call today is entitled Health Insurance Exchanges, Understanding State Options and Deadlines. In just a minute, we're going to go to our experts who will be with us today from the Department of Health and Human Services. But as always, we have a few of those pesky housekeeping details. If you get disconnected at any point from this webinar, you can simply dial back and or reboot your computer depending upon which link you lost, and it won't upset anything on our end or yours. You will be in listen-only mode during this webinar. We will be taking questions this afternoon. In your GoToMeeting console, which is probably kind of up on the right upper corner of your screen, you will see a question box. At any point during the webinar, feel free to type in your question, and we will take up as many of those questions at the conclusion of the formal presentation as we have time for. So please be thinking about your questions as you're listening to the speakers. The PowerPoint presentation and the audio of the webinar will be posted on our CSG Knowledge Center in the next few days. As a participant here today, you will receive an email and that link so that you can review both the PowerPoint again and listen to the audio if you wish. And of course, we always encourage you to share those links with your colleagues as you feel necessary or interested. We are pleased today to have the U.S. Department of Health and Human Services with us. They've agreed to provide the content for this webinar. They are, of course, the experts on health insurance exchanges and state options and deadlines. At this point, I'd like to turn over the webinar to Emily Barson, who is with the Intergovernmental External Affairs Office in Washington, D.C. They provide advice to the Secretary on working with state and local governments and manage an office of about 40 similarly situated officials around the country. Thank you so much.
Great, thanks, Deb, and thank you to CSG for hosting this webinar and this opportunity for HHS to share information. We really appreciate the partnership with CSG, especially at this important time as folks are going into their 2012 legislative sessions and will be doing a lot of policy work on exchanges. We wanted to make sure we could share the latest information that the department has put out and address your questions. This is going to be the first of two webinars on exchanges. A second webinar will be scheduled after the final rules are issued. So I guess without further ado, I would like to open up the webinar for Steve Larson, the Director of the Center for Consumer Information and Insurance Oversight at CMS, and he will be sharing some information, and then we have officials from other officials from CSIO and the Office of Health Reform and Intergovernmental and External Affairs who can be available for Q&A after the presentation.
Okay, great. Well, thank you, Emily, and thanks everybody for attending the webinar. We're going to walk through a series of slides here. I think the ones in the beginning are fairly high level, but just wanted to make sure that everyone, had a common understanding of some of the elements of the Affordable Care Act and exchanges. So we'll go through those pretty quickly and then spend more time on the slides at the back. So if we want to go to I guess it's slide number 2. Okay, again, this is one of the pretty table-setting slides here. Affordable Care Act, of course, was passed back in March of 2010, and it puts in place very comprehensive health insurance reforms in the private market that holds insurance companies accountable, has provisions to lower health care costs, and guarantees more health care choices for Americans, and also has a number of components that will improve the quality of health care delivered to folks over time. It's important to know, I think, that many of the important benefits of the ACA are already in place. For example, many of the restrictions and bans on some of the objectionable insurance company practices are in place. For example, prohibiting rescissions of insurance policies. These are essentially retroactive cancellations of policies after claims are made. There are limits that are placed on insurance companies on their ability to cap the amount of annual benefits that they'll pay each year. Those are called annual limits. So there are limits on the ability of companies to put annual limits on their policies. The problem there was frequently people thought they had comprehensive coverage and then would find out they may only have, you know, $10,000 worth of coverage or even less in some cases. Number of provisions for cost savings for seniors, such as subsidies for those who are in the so-called donut hole, and also help for small businesses. And today, coverage options are available now for many of Americans who have been locked out of the insurance market because of a pre-existing condition. In fact, there are a number of coverage provisions that are already in place. The pre-existing condition insurance program, or PSIP, which has enrolled over 35,000 people across the country who have often severe health conditions that would have made it impossible for them to get coverage, and now have coverage, in some cases life-saving insurance coverage. And just generally, folks should be aware of the healthcare.gov website, which has a lot of information not only about the ACA, but about health insurance plans in each state in terms of the benefits that they offer and base rates that they charge. There's actually kind of the prototype of exchanges in many respects there now with the plan finder function, when you can go on healthcare.gov and type in your state and come up with the health plans that are offering coverage there. What you can compare plans, and you can also look at, as I said, the kind of the base rates that they charge to allow you to compare options that are out there. Go on to the next slide. Of course, one of the key features of the Affordable Care Act are the exchange provisions, the affordable insurance exchanges. And these are new competitive marketplaces that will provide affordable health insurance options for individuals and for small businesses. The small business program is called the SHOP program, but it essentially is an exchange for small businesses. I think most people know that exchanges under the Affordable Care Act are to be operational in each state by January 1st, 2014. Importantly, again, I think as most folks know, that the HHS will run an exchange on behalf of a state that is not ready to go and does not receive approval by January 2013. January 2013 is the date by which a HHS, again, by statute, is required to certify that a state is ready to proceed with an exchange the following year. I will note here that although there's a requirement that we certify states on January 1st, 2013, which is, of course, a little over a year from now, we did, in the regulations that we put out earlier this year, indicate that a state that may not be ready to receive approval on January 13 or receive full approval may get conditional approval if they have made sufficient progress so that we have a good line of sight that they would be ready by January 2014. We'll come back, I think, in later slides to talk about the timeline specifically that's in place now for states. So, again, exchanges, next slide, please, slide number 4. Exchanges are designed for consumers and small businesses, and as I said, they're state-based competitive marketplaces where individuals and small businesses can first find information about health plans and compare qualified health plans. And qualified health plans is a term of art from the statute, and it refers to plans that offer essentially pre-qualified coverage that meets certain standards, both under the ACA and in the states if they impose additional requirements. And it essentially ensures that people shopping on the exchange are going to get quality health care. So in addition to going to this marketplace, which most people think about it as a website, but the law doesn't require that people sign up through the website. So there will be offices, and there'll be phone access to this marketplace as well. So in addition to being a place to find information and compare health plans, the exchange will determine eligibility for a range of affordability options that will allow people to get affordable health care. And by that I mean, when you come in the door to an exchange, you will fill out a simple, seamless application. That application will determine whether you are eligible for, say, the CHIP program, or for Medicaid, or for the tax credits, the advanced tax credits that are available under the law to purchase private health insurance for people that have incomes between Medicaid and CHIP eligibility and 400% of poverty. So it's helpful to think about this eligibility function as really there's a spectrum of affordability options from Medicaid to CHIP to premium subsidies that you get through tax credits. And then if you don't qualify for those, you can, of course, enroll in a qualified health plan, but then you would pay 100% of the premiums on your own. And so these three functions on the slide, which is find information and compare, determine eligibility, and then easily enroll in a qualified health plan or other program like Medicaid or CHIP, is really one of the cornerstones of the exchange, which is this simple, seamless customer experience. And then there are a number of consumer protections that are built into the Affordable Care Act that again ensure quality health care and fair treatment for people that are purchasing insurance through the exchange. We can go to the next slide. So this slide, and I won't go through all the text in this slide, represents really the 5 core functions of what an exchange is, and these are the functions that an exchange will perform, whether it's a state-based exchange or whether if the state chooses not to operate an exchange. This is what the federal exchange will do in a state. And I think, as some of you may know, we have previously circulated ideas around what we call a partnership model or a hybrid model, where it may be a federal exchange, but there may be functions that a state wishes to perform. And so you end up with a situation where you've got a federal exchange, but in some cases, traditionally state functions would still be performed by the state. So in this case, the 5 core functions are what we call the consumer assistance functions, and these are, as you might expect, the education and outreach functions to educate the population about the exchanges and what's in them. What's called navigator management. The statute has provision for what are called navigators, which are entities that, as the name suggests, help people that are new to the exchange kind of navigate through the health plans, educate them, help them to understand their various coverage options. Call center operations, the website management, written correspondence with consumers, all of these things are part of what we call consumer assistance, and this is one of the core functions that an exchange has to perform. Then there's what we call plan management, which, again, as the name suggests, is the process of managing the insurance companies and the products that they're going to be offering on the exchange. There has to be a collection of the proposed rates that the company will file, a review of those rates, a review of the benefit packages, monitoring and oversight of these health plans as they operate in the exchange, and then data collection analysis. So that's plan management. I already, I think, referred to this important eligibility function, this single point of entry for people coming into the exchange, filling out an application, and then finding out which of the range of coverage opportunities they might be eligible for. And then, again, as I mentioned previously, enrollment. We want to make sure that when an exchange is being operated, that people, once they get their eligibility determinations, can then, through the exchange, enroll in the program or the health plan of their choice. And then the last item is what we call financial management. There's first of all, a couple provisions in the Affordable Care Act that provide risk management, reinsurance, and risk corridor programs. And these are all provisions that help insurance companies to mitigate and moderate their risk, especially when they're coming into a new market like the health insurance exchanges. And these are important to the financial stability of the exchanges, and this also is viewed as a core function of the exchange. So we can go on to the next slide. I mentioned earlier that there are state-based exchanges as the ACA requires, and then only if the state opts not to operate exchange would HHS step in either alone or in partnership with the state. We put out regulations earlier this year and really left a lot of flexibility to the states to determine how to implement an exchange that best fits their needs and is responsive to local market conditions. We, at some of our events, sometimes are asked, what's the relative advantage of a state exchange versus a federal exchange? We'll talk about some of the funding issues, but really, one of the primary advantages is that states really have the flexibility to design an exchange that fits their local market conditions and local circumstances, and essentially can control their own destiny in setting up how a state exchange might work. The next bullet illustrates some of the examples of areas of flexibility for the states, starting with the basic structure of the exchange. Some of you may be familiar with the idea that there are what are called active negotiator models, where the exchange essentially requests that plans compete on price with the state, and that the state would negotiate rates. There's an alternative model that some people call just the open market model, and that's essentially if a health plan meets the minimum standards, they can be on the exchange, and the state is not negotiating rates with them per se. So that philosophical choice between an active state exchange or a passive open market approach, that is left to the state to determine how they want to operate their exchange. The process of selecting qualified health plans, other than the basic minimum standards that are in the ACA, states are free to impose additional standards or requirements should they so choose. Some of the rules of the road in insurance market are left to the states to determine, such as network adequacy standards. Those are the standards that health plans have to comply with to ensure that they have enough doctors and hospitals and physicians in their provider network. Marketing standards. Most states have in place today marketing standards that apply to insurance companies. And again, the rules that we put out allow states the flexibility to determine what marketing standards are going to apply. Important issue is the role of agents and brokers in the exchanges, and once again, in the rules that proposed rules that we put out earlier this year, how agents and brokers are compensated and how they operate within the exchange and interact with navigators, that's all left up to the states to determine. So if we can go to the next slide, slide number 7. This is a brief overview of the timeline for states in a little more detail than what we talked about earlier. Again, the basic timeline is states are to be certified if they want to move forward with the state-based exchange by a little more than a year from now in July 2013, and then have the exchange operational. We say by January 2014. In fact, it's a little earlier because there's an open enrollment period at the tail end of 2013 in prep for 2014. But in terms of where we are today, well, today we're providing and do provide a lot of technical assistance to states that are moving forward with their exchanges, and we, on an ongoing basis, continue to review the progress of states. We have the opportunity under the ACA to provide what are called establishment grants to the states. We recently announced that we have 28 states and the District of Columbia that have received establishment grants, and we're very encouraged by that, because that means that you've got over a majority of the states now that have received establishment grant funding and are taking action to move the exchange ball down the field. Right now, and we just modified the deadline for applying for establishment grants through June, the end of June of next summer. However, we did just put out a Q&A last week that really provided even additional flexibility to states in terms of the funding for establishing state exchanges. Again, I think hopefully many of you know that there is funding available for states through this establishment grant process. So funding is provided by the federal government for state exchanges, but even where the state is operating a federal exchange, but there are some functions, as we talked about under the partnership model, to be performed by states, there's funding available for states in those areas as well under establishment grant funding. And what we announced last week was that, in fact, we're going to be able to provide funding awards to states through 2014, which means that there may be, and we know that there are states that are maybe moving slower than others that may not be ready January of 2013, but may still want to have a state-based exchange up and running, maybe later in 2014 or maybe January 1, 2015, a year later. And they're going to be able to continue to come in and get funding awards through 2014 that then can roll over to a later. So we're very encouraged at our ability to provide that flexibility to states to continue their work, even if they're not quite ready on January 1, 2013 or 14. This spring, 2012, we anticipate releasing the application for approval, and then really late summer or fall of 2012, we will start to accept applications from states to get exchange approval to meet that January 1, 2013. Continue to provide ongoing technical assistance, review, and outreach to states as they continue their work. All right, next slide. Okay, slide number 8. And slide number 9, we'll kind of talk about what HHS is doing and then what the states have been doing and will be doing. HHS perspective, we issued a number of proposed rules this summer. I referenced them earlier in terms of what provide states with flexibility, but they also defined some of the areas that we talked about regarding core exchange functions, the structure, details on the top exchanges, the small business exchanges, the administration of the advance payment of the tax. That's the relief that so those proposed rules were issued in July of August last year, and we anticipate in 2012 early finalizing those rules. Guidance state. I mentioned already the federal funding that we've provided for states for planning and establishing exchanges, 8 states in the District of Columbia, and we provided to 6 states consortium what are called early innovator grants to really IT work. Issued a fair amount of technical assistance and provide technical assistance to the states. We've had grantee conferences and periodically, and will continue to issue information technology IT guidance to the state. And then for our part, we have completed federal procurements, build of the federal exchange. So two pieces that we've done procurements on and are proceeding with. One is the actual federal exchange itself, and we're doing that in conjunction with Treasury and IRS. And then what's called the Data Services Hub, which is a function that we will be performing at the federal government to assist states to determine and verify citizenship and certain aspects of eligibility for the programs that we talked about. And that will sync up databases with Department of Homeland Security and SSA and IRS. And then I mentioned earlier, we issued last week and will continue to issue questions and answers to states on a number of issues as they come up. So going to slide 9, what have states been doing? And again, we've been very encouraged with the level of activity in the states that we have seen. Just to kind of kick off a couple of the metrics that we keep track of here and that others do as well. We know that more than 40 states have contracted for the necessary background research into their markets. 21 have completed it as part of their planning grant award. Almost all the states, 46 I think, have consulted with stakeholders, and stakeholder consultation is a specific requirement under the Affordable Care Act, and I think almost or up to 38 states have had regular meetings with the stakeholder groups in their community, which can include the industry and agents and brokers and consumer groups and others, all of whom are interested in the development of state exchanges. Another important metric is 36 states have initiated what we call their IT gap analysis, and this is their assessment of their current information technology platform to help them determine what needs to change and what needs to be improved or modified in order to run the state-based exchange and specifically to have that integrated eligibility process that we talked about earlier. And of those 36 that have initiated their IT gap analysis, more than 20 have completed it, which again is, we think, very promising. And then about 20 states have developed a governance model for the exchanges, and 13 have appointed some form of a governing body, whether it's an advisory board or some other management team in connection with the establishment of the state exchange. Next slide. And then finally on slide 10, just to recap what the goals of the exchanges are, expanded coverage. We know from the estimates that are out there we're expecting significant expansion of a number of different affordability programs in both the public and private sectors. Promote competition, and this is really a very important aspect of exchanges. When you have health plans that are competing on the basis of inequality in a very transparent, easily comparable way where you can look at apples comparisons of health, that competition helps consumers, helps lower prices as well. To create affordable options, again, we talked about this earlier, a range of affordability programs from Medicaid to CHIP to the premium tax credits for individuals up to 400% of the poverty level. And then there are small business tax credits available for coverage for businesses or small businesses who typically employ lower age workers. There are tax credits available not only today, but quality is a big part of the exchange initiative, and we'll be issuing regulations probably next year that will address the specific requirements to the health plans will comply with to ensure that the products that you put on the exchange will be good quality. So that's really a high-level overview of where we are on exchanges, and I think at this point we'll be turning it back to the operator. Or Emily?
Yes, Thank you very much, Steve. That was a very helpful presentation. And as we said, we will post these slides on our website so folks will be able to go back and look at them and share them. We are starting to get a couple of questions coming in. We have one from one of our National Association listeners who says a report came out yesterday that Alaska has opted for a federally run exchange, and that it's their understanding from the report that that will prevent citizens making over 133% of the poverty line from qualifying for premium subsidies. And I guess the question is that a true limitation? And if so, what else should states be looking at if they opt for a federal exchange?
Yeah, well, thanks for that question. I have to confess I haven't seen the Alaska report, but in reference to the question on whether if you're having a federal exchange in your state, whether you are not able to access the federal tax credits, I know that there has been a number of articles posted out there suggesting that somehow if there is a federal exchange in your state that you will not have access to the tax credits. And we clarified in the Q&A, in fact, that we put out last week, and I think IRS and Treasury has previously clarified that that is not the interpretation of the ACA. The ACA permits the federal exchange to provide tax credits to individuals who are between 133 and 400%, just as those individuals would be eligible if there were a state-run exchange. So whether or not there's a state or federal exchange does not impact your ability to get the tax credit assistance in that window of the 133 to 400%.
Okay, well, that's reassuring to know. Another question has come in. If a state hasn't passed a bill yet on exchange, if I guess there are 30 states that don't have governance yet, what must they do, and when must they do something?
Well, there are a number of options for states. I mean, we know that many states will be in legislative sessions from January to sometime in the spring, and some states, of course, have full-time sessions. So during the course of 2012, there continues to be opportunities for states to have legislation passed if they so choose. I think we've also made clear that it depends really on the state and the state law. They may decide that they don't need legislation because either they can utilize existing laws. There's a state that's utilizing their legal infrastructure for high-risk pools in one case, and you have governors in some cases that have and may decide to issue an executive order, and they have the ability to do that to set up the necessary legal authority. So the law does not require legislative action per se. It simply requires that there be the legal authority under state law to implement an exchange, and that can be done through the mechanisms that I just described. In terms of what states can be doing, you know, one of the most important things is to avail themselves of the opportunity for establishment grants if they have not done so. And I think I mentioned that, you know, we extended that deadline for applying for an establishment grant through next June, and in fact we anticipate further extending it to sync up with the timelines that I described earlier, in which a state that's making progress towards establishing exchange functions could continue to get funding through 2014. So there's a lot of opportunity there. And I think time as well for states to take whatever necessary legal action they may have to take to get their authority in place.
We have sort of a follow-up question from someone who asked us not to mention their state, and it sort of reads along the lines of, my governor is not very interested in a health insurance exchange. How far could the legislature go on its own?
Well, that's a little bit hard to answer in the abstract. Again, it is not a requirement to get establishment funding from HHS that there be kind of a gubernatorial ironclad commitment to build an exchange by a certain date. We do have to see a plan for how you're going to get there and what permissible functions are going to be funded. But we know that we have states now who have not yet passed, say, legislation to move forward, who are getting establishment funding now. We've got almost 30 states that are getting establishment funding, and I think 12, 13 states that so far have established legal authority. So that's the big opportunity out there, and we encourage states to do that, even if, say, their governor hasn't yet enacted an executive order or the legislature hasn't yet passed a bill.
Okay. And this is sort of similar but a little different twist that ask, essentially, given the 2013 and 2014 requirements, but what prevents a state from opting out now and just waiting until later to set up their exchange? And if they do, will their state exchange replace the federal one?
Well, it's a good question, and we've gotten that in a number of forms. I mean, the benefit of moving forward, now with an exchange, and in the timeline that I indicated earlier, is the availability of federal funding, which now, again, we can make awards through 2014. But after that 2014 date, we are not going to be in a position to continue to make awards for a state exchange. So if a state believes that it wants to move forward with an exchange, it should take advantage of the federal funding that's available now to do so. In terms of the question on does one take the place of the other, essentially yes, although it's more complicated than that. But under the law, if a state is not ready to go on January 1, 2014 and hasn't been either fully or conditionally approved in 2013, the federal government will operate the exchange in that state. But yes, a state could look to transition the federal exchange over to a state exchange along with the funding stream that I talked about earlier. So there would be a transition that would occur between the exchange that the federal government was operating and then kind of the go-live date, say July 1, 2015, that a state might proceed with.
We have two questions that ask about the basic health plan option, which is a little different than the exchange conversation, but it at least has risen to the top for two of our listeners. One is specifically asking when will the rules be issued on that, and the second question is, do you know which states plan to offer the basic health plan option, and is it still a serious consideration for many? And you might want to explain just a little about what that is for our callers who may not know.
Sure. I mean, I can say it's a little early for us to know which states may be seriously interested in proceeding with the basic health plan option. The nutshell version of the basic health plan is that essentially a state can decide to extend a Medicaid-type program to what's called a basic health program and use 95% of the money that would have otherwise been available for tax credits for individuals up to that 400% of poverty, and I think basic health would go up to 200% of poverty. So it's an add-on program, and then there's, as I said, the funding that would be available in lieu of certain tax credit money. We've provided some guidance on how research and development of a basic health program can be funded through the exchange grants, which is largely cannot be. And we expect, hopefully, in the near future to put out additional guidance on the basic health plan sometime next year.
Okay. Another sort of, when will you be defining things? What is the status of the definition of essential benefits?
That we understand how important that is for states and governor's offices and state legislatures and others to know how we will be approaching the essential health benefit issue. I think most people on the phone may know that the way that the ACA is structured, qualified health plans will offer essential health benefits, and if state law requires under state mandates additional benefits, then the state is essentially on the hook to pay for those. So there's a lot of interest in how EHBs will be defined and how they're going to match up with the state levels of mandates, and we've heard that message over and over again, and we are planning to release guidance on essential health benefits by the end of the year. That was our commitment earlier this spring. I know many of you are aware that the Institute of Medicine put out a report that referenced dates out into May of next year, but we are going to do our best to stick to our announced timeline of putting guidance out by the end of this calendar year in advance of sessions that will start in 2012.
Okay. We have a question from Maine that asks if the states that opt for the federal exchange, if all of those states will have the same insurance product options, or if you anticipate that they will differ from state to state, even if the federal government is running that state exchange.
Well, all of the details regarding the federal exchange have not been announced yet. We, at a high level, will attempt to balance two different interests. One is, to the extent practicable, we want to tailor the federal exchanges to the state circumstances as best we can. But as people may understand, there's a point at which that becomes more complex and creates operational risk for the federal exchange. So we have to balance our desire to have a very state-centric exchange, even when it's a federal exchange, with our obligation to make sure that we have exchanges operating in every state that doesn't have a state exchange. In the Q&A that we put out last week, we did make clear as a general matter that where we can, we're going to rely on state processes and particularly the historic functions of the state departments of insurance. In terms of the specific plans that may be offered, it's a little early for us to talk about which plans might be offered where. We certainly, I think, hope that local plans will want to participate in the exchange, even if it's a federal exchange, and it will be our goal to do everything we can reasonably and legally to make sure that we can get those local plans in those federal exchanges.
Okay, there's another question that asks, if states do not receive if they're not certified as ready in 2013 or have conditional approval, sort of the question is, what happens? What will you do with those states?
Well, in those states, again, the law requires that we would operate a federally, what we call a federally facilitated exchange. It would certainly be our hope and goal and objective that even in states where we're operating a federal exchange, that we will have a collaborative working arrangement with the state, and we would begin that dialogue, as early as the state is ready to have that dialogue with us, to start talking about steps we can take to get the federal exchange going in that state.
Okay, and here's sort of a nitty-gritty question coming from Nevada that asks, how do the advanced tax credits work for potential recipients? I guess a little more detail as to how that would actually work.
Well, I mean, at a high level, when I talked earlier about this eligibility process, and just say someone comes in as 250% of the federal poverty level, so they're below the 400% that makes them eligible for the tax credits, the state or federal exchange would reach that eligibility determination. That individual would then be able to enroll in a qualified health plan, but would have access to these tax credits that would lower the premium that they would otherwise have to pay if they were just paying kind of the full premium without this assistance. At that point, the mechanics of how the tax credit makes its way to the insurance company, that gets a little bit more complicated, but what I just described is the basic structure.
So from the recipient's viewpoint, they don't have to pay money out at the front end and wait to get money back at the back end with a tax credit.
That's right. It's an advanced tax credit, meaning that your obligation to the insurance company is reduced by the value of the tax credit you get. So the premium that you have to pay in the first instance will reflect the value of that tax credit that was adjudicated to be available to you.
Okay, we have another sort of detailed question about states, how states are dealing with the differences in verification procedures between the health exchanges and Medicaid. I assume that would be income and eligibility verification, rules and procedures.
I'm sorry, so the question was what exactly?
I guess the first question is there a difference between requirements for income verification between the exchanges and Medicaid rules? And if there is a difference, how are we going to deal with that difference?
Well, there are differences and can be. I mean, even though the proposed rules, significantly simplified Medicaid eligibility and collapsed many of the categories that existed before into to this, modified adjusted gross income approach, or what's called MAGI. The regs still provide some latitude among the states to use other verification sources other than what's in the regs. So you can, first of all, have some variation among the states. And yes, there are some differences between the MAGI the determination of income for Medicaid purposes versus for tax credit purposes, because one is kind of a current income approach and one is an annual income approach, and there are differences. It's those differences, frankly, that creates the preference that we've expressed in our rule for an integrated eligibility engine or system, so that that's all done in one place at one time. I should mention that in the Q&A that we put out last week, one of the things we did, and this was in response to state feedback on the proposed rule, was we did make clear our intention when we finalized these rules to, for example, if a state is going to run a state-based exchange, they have the ability to continue to make Medicaid eligibility determinations, but essentially utilize a federal tax credit capability. So it does result in some separation of these eligibility determinations, and it will be up to the exchange to make sure that we can harmonize those and people and consumers don't get caught in the switches in that process.
Okay, we have a question from Tennessee that sort of goes the opposite direction and asks, if states start an exchange, will they be able to withdraw and have the federal government operate the exchange if their costs exceed initial plans?
Yeah, I mean, I don't think anything that we have put out in our regulations to date would prohibit a state from starting and then stopping. I think we mentioned earlier that there is federal funding available for a state to continue this through the awards through 2014, and then even funding from an award beyond 2014. So certainly we would hope that a state that started this activity would continue building the exchange at a state level while the funding was available.
Okay. A private sector question, will states charge user fees on employers or insurance companies? And can a state or federal exchange include large employers in the exchanges? I guess those are two sort of separate questions. One is the user fees, and then one is large employers.
The ACA and the proposed regulations that we put out earlier leave broad flexibility to the states to determine how ultimately the exchange will be financially self-sustaining. And there are, as your question suggests, a number of different models. You can have state support, for example. You could have fees on individual folks who get their insurance through the exchange, or user fees of another type, or fees on insurance companies. There's a whole range of various options, and that decision is left to the states to determine how ultimately they want to fund their exchange.
Okay.
Deb, there's maybe one or two quick more questions, and we're going to need to.
I was just going to do the wrap-up.
Wonderful. Thank you.
We thank you so much for loaning your time to us today. And we had at least 100 callers, more than that, here and there on the phone call today. So we've really hit a topic that's near and dear to the hearts of at least our members out in the state. So we thank you very much for that. As both the federal office and we have alluded, we do plan to have a second webinar in this series after the additional guidance comes out from DHHS. In about a month or so, we'll be putting together that webinar. And those of you who are on this one know how to find out through our membership communications, and you'll be receiving information about that. I'd also like to let you know that our federal friends have said that if there are follow-up questions that you would like addressed, that an email address they have provided, sort of a long string of initials, HHSIEA@hhs.gov.